This is PT Pro Talk, the podcast for physical therapists who want to improve their clinical skills and be more successful. I'm Mariana Parks, physical therapist and your host, and today I'm sharing my conversation with Dr. Joanne Kemp as we discuss hip pain. In this episode, Dr. Kemp covers the most common hip diagnosis, how to differentiate between various hip conditions, key clinical tests and red flags to watch for, the most effective treatment approaches, when surgery is considered and what factors influence the decision, and much more. Joanne is an associate professor and deputy director at Trobe Sport and Exercise Medicine Research Center, where she leads the hip pain research program. She is also the academic director of Trobe University's clinical trials platform and a sport and exercise physiotherapist with over 30 years of experience. A fellow of the Australian College of Physiotherapists and an editor at the British Journal of Sports Medicine, she has authored over 160 publications and secured more than $13 million in research funding. Her work focuses on managing hip pain in adults, particularly interventions to slow progression and alleviate symptoms of early hip osteoarthritis. If you find our conversation informative, please subscribe to our channel, hit the notification bell for updates, give us a thumbs up, and share this episode with colleagues who might benefit from these insights. Thank you for tuning in, and let's dive into the discussion. PT Pro Talk is only possible with the support of the forward-looking and innovative companies like
Welcome to Urban Polling. Discover the Activator program and polls for rehab and balance.
Sarah Health. Remote therapeutic monitoring sounds great, but also difficult. Sarah Health makes RTM simple and easy for your patients and providers. Check out sarahealth.com/PTProTalk for a special offer. Hi, Joe. Welcome to PT Pro Talk. How are you today?
I'm very well, thanks, Mariana, and nice to be here. Thanks for the invitation.
Awesome. So let's get started just talking a little bit about yourself and your background.
Yep, sure. So I'm a physiotherapist. I'm based in Australia, in Melbourne, Australia. So my main role is at Trobe University at the Trobe Sport and Exercise Medicine Research Centre, where I work leading our research program into hip pain. So we have a number of different projects looking at hip pain in sort of across the spectrum from adolescents all the way through to older adults, and we have a great team that works in that space. And I also work clinically at a physiotherapy clinic in Victoria, still seeing patients primarily with hip pain and associated injuries as well. So I'm a sport and exercise physiotherapist and have been for probably over 30 years now. So have been seeing patients with hip pain for a long time clinically as well.
Before we continue our conversation, I wanted to take a quick moment to present you to our sponsor, NeckCare.
Traditional neck assessment methods often fall short of providing a full picture, overlooking movement control and sensory motor integration. That's why a physical therapist developed the NeckCare system to provide reliable assessments of sensory motor integration, proprioception, and range of motion. With objective data and visual results, physical therapists can better understand neck impairments and design targeted treatment plans for optimal outcomes. If you treat neck impairment in your practice, visit neckcare.com to learn more.
And now, let's get back to our conversation. That's awesome. A good combination of research and practice. Very good. So let's jump to our topic, hip pain. So what are the most common diagnoses that you see in your patients with hip pain?
Yeah, look, it's a great question. And I think something that's been really helpful over the last 10 years is that there's been a really great evolution of consensus statements that have really helped us clarify how to categorize hip pain and how to classify hip pain. So 10 years ago, back in 2014, the Doha Agreement took place, and this was an agreement that looked at how we classify hip and groin pain. And at that agreement, it was decided that you could classify patients who present with hip and groin pain where you know it's not arthritis and it's not a red flag cause of pain, that it could be classified as either adductor-related groin pain, iliopsoas-related groin pain, abdominal or inguinal-related groin pain, or pubic-related groin pain. And then the fifth classification was hip joint-related groin pain. And then in 2018, we met in Zurich and we had the Zurich Consensus Agreement. And at that agreement, we took that classification of hip joint pain and broke that down into 3 categories. So either femoroacetabular impingement syndrome, or FAI syndrome, is the first classification of hip pain. The second classification of hip pain was hip dysplasia or hip instability. And then the third classification of hip pain was hip pain with normal hip morphology, so not with the abnormal bone shape that you see in FAI syndrome or that you see in hip dysplasia. So other causes of hip pain where the shape of the joint is normal. And so that, I guess that those 3 classifications of hip pain made that more clear. And then in 2016, the Warwick Agreement took place in the UK, and what that agreement did is it took the classification of FAI syndrome and said that for patients to have FAI syndrome, they needed to have all 3 of positive imaging findings that you see in FAI syndrome. So that's typically the extra bump of bone that you see in CAM morphology, but also could be pincer morphology where you have a deep acetabulum. Then they had to have positive imaging findings. They had to be symptomatic. So there's no such thing as asymptomatic FAI syndrome, that the patient had to have pain. And then finally that they needed to have the positive signs that you see with FAI syndrome. So potentially positive impingement tests, limitations in function, reduced strength and those sorts of things. So I think from putting all of those sort of consensus agreements, which were based on the research evidence and what experts think, being able to classify groin pain as those 5 entities, and then taking hip pain and being able to classify it as one of the 3 things, and then having a clear understanding of what FAI syndrome is, just gives us a really nice basis that when a patient presents in the clinic, the way I like to think of it is I have those classifications right at the front of my mind when I see a patient. So they'll come in and I'll rule out things like lower back pain or other causes of pelvic pain, and then I can really try and be very clear in classifying the patient's presentation as one of those clinical entities, because I think then once you have that clear classification and diagnosis, it really helps you with the way you plan to treat the patient and the sorts of treatments that you develop for the patient.
Oh, that was a great overview. I wanted to go back and ask you about the groin pain related, those 5 things that you mentioned. So how do you go about diagnosing that groin pain?
That's a great question, and it is really tricky because it's really nice in theory to say it's going to be one thing or one thing, but in reality there's a big overlap between the conditions. So the way I like to think about it clinically is, even though they might have 2 or 3 of the different presentations, what's the primary driver and what's the most important one to present? So to diagnose that, a lot of our clinical tests have really good sensitivity, which means that they're very good at ruling out the condition, but really, really poor specificity. So they're not so good at diagnosis. So it's generally a little bit of a process of elimination. So, and the clinical utility of a lot of these tests hasn't been fully established in the literature. So some of this is based on research and some of it is just clinical experience. But to be able to work out which of those 5 clinical entities, so whether it's adductor-related pain, hip flexor-related pain, abdominal-related pain, pubic-related pain, or hip joint-related pain, the site of the location of the patient's pain can really, really help, because all of those structures are actually quite separate. Even though they all sort of appear in that groin and anterior hip region, they are quite different. So the first thing I do is I ask the patient to point very specifically where they feel their primary pain. And that gives you a lot of information. So if they point down in their adductors or over their pubic bone, then it's probably not abdominal-related pain. Whereas if they point, into their lower abdominal region, it could be more likely to be hip flexor or abdominal-related pain. So I think the first thing is the location of the pain. And I like to be really specific with the patient and ask them not just where you feel any pain, but where do you feel the pain that has brought you to seek treatment? So where do you feel your main pain? Because often these patients will have pain in different areas, but asking them, where's the main pain, the most important pain to you? So the pain location is the first thing that I look at. And then palpation is really, really important with these patients as well. So I'll always ask my patient if I can palpate the structures, and then palpating all of those different structures. So having a really good understanding of the anatomy of that area, of the groin area, is really, really important, and being able to palpate the structures. And then again, asking the patient, when I touch that structure, does it reproduce your familiar pain or your most important pain? When you're palpating, obviously there are certain things you need to take care of when you're palpating those structures in patients who are men and patients who are women, because there's different other anatomical considerations with their genital organs and those sorts of things that you have to be really, really careful and respectful of with palpation. So pain location is first, palpation is second, and then the other thing that you can then use are some of your clinical tests, which we do know have some utility. So the flexion adduction internal rotation test, or the FADIR test, is a good test to help rule out the hip joint as the source of pain. So if you do that test and it does not reproduce the patient's pain, then you can be fairly confident that the hip joint is probably not the source of pain, and so you can potentially rule that out. You can use your resisted test. So the Copenhagen squeeze test actually has a really good diagnostic accuracy, so a high level of specificity. So with that test, that's when the patient lies with their legs out straight and you resist them adducting their legs or squeezing together. If it does reproduce their pain, so their adductor pain or their groin pain, then you can be fairly confident that their pain source is potentially the pubic or adductor related pain. And then doing some of your other manual muscle tests, so resisted hip flexion, resisted abdominal contraction, can also help you identify whether those structures are the source of pain as well. So using that combination of pain location, palpation, and some of our special clinical tests can help you understand what the source of the patient's pain is. But also doing a really good subjective assessment is important as well in these patients. So having a clear understanding of their history of their pain, how their pain developed, what sports they play, what their family history is as well. All of that information is really important to sort of help you classify into one of those 5 potential sources of hip and groin pain.
So just continue. It was so interesting, everything that you mentioned, and I wanted to ask you about the abdomen-related groin pain. So, how do you treat that? What does that mean? You're gonna do the test, the location, and what are the causes of that? Is like a pain that radiates to the groin, but the cause is,
Yep. It can be. So the first thing I want to say is that all of our research, the research that I've done has not been in abdominal related groin pain. So so this is purely based on my clinical experience. So the research that I've done has been very much in the hip joint related pain, and that's where we have a lot of the evidence that we can talk about. But in terms of abdominal related groin pain, yes, it can. It usually, the source of pain is often in the abdominal area, but it definitely can radiate into the groin and even can radiate down into the leg somewhat. In terms of the cause of the pain, that's a really, really good question, and it is commonly seen in athletes who play kicking sports. So football, all the different codes of football. We have a lot of Australian football here, so it's commonly seen in those kicking sport athletes and those change of direction sport athletes, and it's more commonly seen in men than in women just because of the anatomical structure in that area. But that's not to say that women don't experience abdominal related groin pain. And if a woman presents with abdominal related groin pain, the other thing that's really important to think about is that all of their gynecological organs sit in that same area. So all of the reproductive organs. And so it's really important in a female patient who presents with abdominal related groin pain that you ask them questions about their menstrual cycle and about any other sort of gynecological history that they might have as well, so that you can be really clear whether or not there's an influence of their reproductive system and their gynecological organs on the pain that they're experiencing, because that in women who present with abdominal related groin pain, there is often that overlap there, and that is something that you need to be conscious of.
And like all these groin pains, they are usually like they are referring the pain to the groin. When you say they're like from like the hip joint or the pubic area, abdomen, psoas. So all of these pains, they are just like referring to the groin. Is that what you mean when they are related?
Well, the thing with groin pain is it really refers to any pain in that front of the lower abdominal area. So it can be from the outside of the hips all the way into the center to the pubic region. So the term of groin pain is a big umbrella term that refers to pain right across sort of that front area of the lower pelvic region. So, and that's why the pain location is important. So when we say groin pain, pubic related groin pain will be very central right over the pubic bone, which will probably be different to hip related groin pain, which will be slightly to the side and slightly up a little bit over the hip joint, which will be different to adductor related groin pain, where it will be down underneath the pubic bone near where the adductor tendons are. So even though they're all called groin pain, the location can be quite different for each of them.
Mm-hmm. Okay, so it's just they are close to a different structure that refers to that area.
Yeah, absolutely.
Okay, and then now going to the hip classification. So the third one that you said is pain with like normal anatomy, right? The structures. So do you have other sub-classifications for that? Like, or do you have everything, all the pains, the normal hip pains are there?
Yep. So what we're talking about with the hip joint classification is hip joint related pain. So there can be other causes of hip pain that could be related to tendons or muscles. So this is not referring to those. So this is referring to intra-articular hip pain or pain that's coming from the hip joint itself. So in that other category, that's not FAI syndrome and not dysplasia, where the bone shape is normal, that generally refers to things like tears to the labrum, to the acetabular labrum, injuries to the articular cartilage, or tears to the ligamentum teres, which is the big ligament that sits within the hip joint. So they can be sources of pain coming from inside the hip joint that can occur. They more commonly occur when the bone structure is abnormal, so they more commonly occur with FAI syndrome or dysplasia, but they can also occur without that abnormal bone structure.
Okay. And so now talking about the clinical tests, so how do you differentiate between those?
It's very hard to do that clinically, and it's almost impossible to differentiate between the labral tear, the articular cartilage tear, and the ligamentum teres tear. There's not really any clinical tests that help us do that. There is one test called the ligamentum teres test, which was published by John O'Donnell several years ago, that does actually have good sensitivity and specificity to identify a ligamentum teres test, but it's actually almost impossible clinically to differentiate between those structures as the source of pain without using imaging. So you would need to use some sort of imaging, such as MRI imaging, to really be able to determine what the source of the pain is. But the other thing that you have to be careful of with MRI imaging is that people will often have potentially all of those things happening at the same time. So the person might have a labral tear and also a cartilage injury and a ligamentum teres injury at the same time that they have all together. The other thing with imaging as well that we have to be careful of is that there's a really high prevalence of those findings on MRI scans in people who don't have any hip pain at all. So you can have a labral tear or a cartilage injury or a ligamentum teres tear and have no symptoms. So you have to be really careful when you're getting an MRI of someone that it's not just a coincidental finding and that it is actually the source of their symptoms. So you need to match it up with their clinical presentation, so all of their subjective findings and their history, and also the results of your clinical tests and the imaging, and bring all of those things together to be reasonably sure that that's what the source of the pain is. But even then, I don't think clinically we can be 100% sure of what the source of someone's pain is, because as we all know, pain's complicated. It doesn't just come from structures. There's all of the central components that can contribute to pain that actually don't have anything to do with the structure of the tissues that you're looking at. So you can never be absolutely 100% sure of what the source of the patient's pain is clinically.
Yeah, and that's complicated because then you send them to an MRI and then you find a lot of things.
Exactly.
And then you know that they start, creating all those things in their head, their expectations and all those names, and they get scared, and then they, believe that that's the source, and then they go to the doctor, they want to do surgery, and then all the trouble starts.
Absolutely. That's so true. And so by the time I see patients, they'll have often had their scans done. So I won't refer them for a scan. They might come with their scan. But if someone hasn't had a scan done, you absolutely have to be really careful before you go and send someone for a scan, because you need to be prepared to be able to explain the findings to them and help them understand what's important and what's not important. Understand that we see these findings really commonly, particularly as people get older. And the other sort of rule that I have is, if I'm referring someone off for a scan because I suspect that there could be a red flag, because we need to remember that sometimes patients with cancer can present with pain in this area, particularly metastasizing breast cancer or prostate cancer or bowel cancer, that if you find a red flag, you need to be able to explain what that means. And so if I suspect a patient has a red flag, I'll always actually send them to their doctor, to their medical doctor, to get their scans done, because I don't want to have to be the person interpreting and explaining the findings of those scans if I do suspect that there's some sort of red flag like cancer. So you're absolutely right. If you're getting a scan, you have to be prepared to spend a lot of time with the patient explaining what the scans mean and what is worth worrying about versus what's not worth worrying about.
And like you said that you refer to an MRI when you suspect of a red flag, right? So other than that, do you refer them to get an MRI when you're to get the right diagnosis? Is that important to your treatment? So how do you go about that?
That's a great question. And I think that wanting a diagnosis is really complicated, because a lot of the treatments that you'll do will be this kind of similar, whether the patient has the labral tear or the cartilage injury, or whether they have FAI syndrome or hip dysplasia. There's a lot of overlap and similarities in the treatment. So I won't refer for a scan just to get a diagnosis. But I will refer for a scan if I've been treating a patient for a few weeks and there's no sign of improvement or they're getting worse. I think that that's really important at that point in time to look at getting a scan. Sometimes the patients want a scan, and they want a scan for their own peace of mind, either to rule out the red flags, or we've done some qualitative work that has shown that patients actually really like a diagnosis. So they want to know themselves what's wrong, because it helps them understand the problem and make decisions around what treatment's going to be best for them. So often the patient might decide that they would like a scan just themselves for a diagnosis. So when I make that decision about referring for a patient for a scan, it's a shared decision. It's a conversation with the patient. So I'll talk to the patient and say to them, we could get a scan, and if we get a scan, we're most likely going to find FAI syndrome, for example, or we're most likely going to find hip dysplasia, and it might change the treatment slightly towards a particular direction. It might be important for the patient's prognosis as well, and decision around whether or not surgery is appropriate for that patient as well. But particularly if the patient's condition is worsening or not getting better, then I'll potentially look at sending them off for a scan.
Okay. And how about soft tissue problems? So tendinopathies and all the other issues. How do you go about those?
In terms of the diagnosis or the treatment, or diagnosis.
Yes. So we talked about the joint, right? So now just going a little bit outside.
Yeah. So it depends a lot on the age of the patient as to what sort of problem they'll have. So if it's an adolescent athlete, then it's quite common to see the apophysitis around the groin area. So you can get pubic apophysitis, you can get apophysitis at the AIS, the ASIS, and other bony muscular attachments. So in the adolescent athlete, it's really important to understand whether that's the possibility. So in terms of the diagnosis for that, imaging can be really, really helpful in those situations to look at getting some scans done for that patient. The pain location and palpation is important. Muscle, like stretch tests, can be really important, and resisted muscle tests, but also the mechanism of injury is important here. So often these athletes will have had a rapid increase in their load or their training over a short period of time, and that's the point where, and also potentially periods of growth. So you'll often see these apophysites around the time that the athletes might be having a growth spurt. So putting together questions around their training load and their sport, their growth, whether they've previously had a problem. So patients may have had something like a Sever's disease or Osgood-Schlatters disease, and then they present with a pelvic apophysitis. So they'll often get, have the same problem in multiple joints. So that's what you'll commonly see in the adolescent athlete. If you have an older athlete, then we do need to think about the tendinopathies. So particularly in women who might be in their 40s and 50s who are potentially going through menopause or perimenopause, they will often present with gluteal tendinopathies, or proximal hamstring tendinopathies can be really, really common in these patients as well. So in terms of the diagnosis for those, again, the history is important, asking them about their hormonal and menstrual cycle, like are they perimenopausal or menopausal, is really important to understand. The location of their pain, and then some of the palpation as well. So in the cases of gluteal tendinopathy or proximal hamstring tendinopathy, they'll often be very tender to palpate right on that attachment of the tendon. And then imaging can also be helpful in these patients. But again, I'm not sure that imaging, you can often get a pretty clear understanding of the diagnosis without imaging. But for some patients, again, if their problem's not resolving, imaging can be helpful to help understand the severity of the problem and their prognosis, recognising that those tendinopathies are not something that responds well to surgery generally. So imaging is less helpful in terms of the decision-making, whether or not someone would go to surgery, but more helpful from potentially the severity of the problem and their prognosis.
Okay. And now jumping to treatment, you mentioned that they are very similar in a lot of cases, right? So what are the main things, the exercises, or what are the things that you do to treat them?
Yep, so that's a really good question, and there's a lot of commonality in the treatment for all conditions, but then it can be a little bit specific. So I guess the first thing to say with the treatment is what I'll always try and do is get an understanding of the particular patient's impairments. So I will always measure their muscle strength using a handheld dynamometer so that I can understand whether there are deficits in their muscle strength. So if we're thinking about the patient that presents with FAI syndrome, what we want to try and do is have an impairment-based approach to their treatment. So we know that these patients will have restrictions in their range of motion, and they'll also have restrictions in their ability to do functional tasks. So they'll have poor balance, poor control, motor control of their pelvis and their femur, so poor movement control. And then they also have weakness around their hip muscles, so in particular their hip adductors and their hip extensors, but also the abductors and flexors, and also weakness around their trunk muscles as well. So the treatment for those patients with FAI syndrome very much focuses on hip muscle strengthening, so particularly strengthening hip extensors, hip adductors, abductors and flexors. Also trunk muscle strengthening is really important in those patients. But then I'll also really make sure I include some functional and movement control and balance exercises as well. We have an RCT that we have it's currently under review at the moment, where we found that patients did really well with FAI syndrome, whether you gave them a targeted strengthening program or a stretching program. So there seems to be an element of just getting the patients to exercise is as important as the specific type of exercise. So some patients respond really well to stretching. And then the other thing that's really important is improving their physical activity. So getting them to do general physical activity, whatever they want to do, which could be bike riding, it could be walking, it could be swimming, but really trying to encourage them to meet the physical activity, the WHO physical activity guidelines that say we should be trying to do 150 minutes of physical activity each week plus 2 strength sessions. So that's sort of how we treat FAI syndrome. And then if we think about hip dysplasia, there's a lot of overlap with what we do for FAI syndrome, but there are some specific things with hip dysplasia that you need to focus on that you don't focus on as much with FAI syndrome. Because if we think about FAI syndrome, the actual joint is it might be impinging, but it's quite stable. Whereas in a joint with hip dysplasia, the joint is quite unstable, particularly in the rotational activity. So when we're treating someone with hip dysplasia, we need to have our exercise focus on rotational stability as well of the hip, and also targeted strengthening, particularly of the hip flexors and the hip abductors, because those patients often don't have their acetabulum might be too shallow laterally or too shallow anteriorly. So it's really important that they actually have big, bulky hip flexor muscles and hip abductor muscles, because they actually act like a wall around the hip joint. So strengthening those muscles is more important in someone with hip dysplasia than it is in someone with FAI syndrome. So and also giving that rotational stability and control, because the patients with hip dysplasia don't have that. So there are some differences between dysplasia and FAI syndrome. In terms of those other hip joint conditions that we talked about with normal morphology, again, it really depends on the patient's impairments, but we would take a similar approach to what we do with FAI syndrome, in that we would be trying to work out where their muscle weaknesses are and give them hip strengthening exercises for those muscle weaknesses, as well as strengthening up their trunk, giving them good movement control and making sure they're physically active. So that's sort of how we treat hip joint pain. And then the treatment for the other causes of hip or groin pain, it depends on the condition. If we're looking at tendinopathies, so either, gluteal tendinopathy and proximal hamstring tendinopathy are quite common. And there have been some studies that others have done in this space where they've found that a graded muscle exercise approach can be important, particularly starting with isometric strengthening for either the hip abductors or the proximal hamstring, and then building from there to build into more movement-related muscle strengthening exercises as well.
Okay. And how about hip osteoarthritis? Where does it fit on that classification?
Yeah, it's a good question. So hip osteoarthritis is different. So those classifications are for, I guess, what we call non-arthritic hip pain. So hip pain that's not arthritis. But absolutely, hip osteoarthritis is a big problem. And I think once a patient is sort of in their late 30s or older, we have to be really conscious that hip osteoarthritis can be a common cause of pain. And if they have a history of either FAI syndrome or hip dysplasia, we know that those two things increase the risk of getting hip osteoarthritis in older age. So I think if someone has a history of those things and they're over 40 and they have pain in their hip or groin area, then we definitely need to think about hip osteoarthritis. So if someone has osteoarthritis, the common things that we'll see is actually a loss of movement, a loss of range of motion. So they'll report difficulty doing things like putting on their shoes and socks is a really classic one, or getting in and out of the car where they've lost the movement, lost the flexibility to be able to do those things. They may also have some stiffness in their hip joint, particularly in the morning, but the stiffness will only last a short period of time, and then once they get moving, the stiffness improves. And they may also have sometimes people with osteoarthritis also complain of like the locking or the catching in the hip joint or the clicking and crunching in the hip joint as well. So, but particularly that loss of movement and some stiffness in the morning as well as the pain in that area and a history of FAI syndrome or hip dysplasia, can suggest osteoarthritis. Also, if someone's had a heavy manual job, so if they have worked in a factory or worked as a farmer or something where the work is very heavy, that increases the risk of osteoarthritis. So understanding someone's occupational history is really important. And there's also a higher risk of people with osteoarthritis if they've done a lot of sport. So if they've been an elite athlete and played sport a lot, they also have an increased risk of developing hip osteoarthritis in later life. So using all of those things can help you come up with a diagnosis of hip osteoarthritis. So you don't need to get an X-ray to diagnose osteoarthritis. You can diagnose it based on those other criteria. But people with osteoarthritis will often come and they might already have had their X-ray done, and you can see the osteoarthritic changes on the X-ray.
Okay. And then regarding the treatment for those patients, is it similar to the ones that you were previously mentioning?
Yeah, it's a good question. And so it's sort of similar but a little bit different. So there've been some good studies done that have looked at the effects of different types of exercise on osteoarthritis and the effects of manual therapy compared to exercise on osteoarthritis. And what the studies show is that exercise is more effective than manual therapy for osteoarthritis. And the exercise programs can be land-based exercise, so strengthening exercises, so programs like the GLAD program. But it can also be water-based exercise if the person prefers water-based exercise. So in the short term, both water-based, so hydrotherapy exercise, and land-based exercises are both equally as effective. But the exercise program should have a focus on range of motion and also strengthening of the hip muscles and the leg muscles more generally, so strengthening quadriceps and hamstrings and calf muscles, strengthening up the trunk muscles as well, and then general physical activity and fitness. So yeah, the flexibility exercises, the strengthening exercises and the general physical activity are really important for people with hip osteoarthritis, and they can be done either in the water or on land, depending on what the patient's preference is as well.
And talking about GLAD, I was checking that today again because I remember I had an interview with Christian Barden, and he was talking about the knee. And then I went back to look at it, and I wanted to confirm with you. So like you use the same exercises for knee and hip, right?
Yep. It's a good question.
Now that you mentioned that you do the whole body, lower leg. So
yeah. So that's right, because we know with the knee, and Christian will have told you this when you chatted to him, that it's really important that people with knee arthritis are strong around their hip and their trunk, because the hip and the trunk control the pelvis and control the femur, which has a big impact on the knee. But also more broadly, it's really important for someone's general physical fitness to focus on those things. And similarly with the hip, that we use very, very similar exercises in the GLAD program for people whether they have hip arthritis or knee osteoarthritis. So they can both work really, really well. With our GLAD data, it does seem as though the knee does a little bit better than the hip with GLAD. Both groups do really well, but the knee might do a little bit better than the hip with GLAD. And we're not really sure what the reason for that is. We're doing some work at the moment to try and understand that better, whether it's got to do with the exercises, being maybe the people with hip need something slightly different, even though the GLAD program works really, really well for them. But it could also be, we also think it might have something to do with the point in time at which people present to treatment. So we think that with the knee, people might, the trajectory of knee arthritis is sort of more gradual and slow. And so people will present perhaps a little bit earlier for treatment. Whereas with the hip, I think people can go along and feel pretty good, and then their deterioration is much faster. And so it might be that if they're not presenting for treatment until they've already started that really rapid deterioration, that perhaps those people are not responding as well to the GLAD program either. But absolutely, both the exercises are very similar for both knee arthritis and hip arthritis, and can be very, very effective in both groups.
Yeah, and I encourage people to go check it out, because you can have access to the exercises on the website. You can just download them. Yeah.
Absolutely. They're all there on the website.
Yeah, and I also was looking at one of your papers today, and one of them had like a little protocol of exercises. I I think, I don't remember now if it was hip osteoarthritis or if it was impingement, I guess, right? That you had that list. So it was very helpful to just take a look, and then it was like hip extension and a few different types of hip extension, adduction, abduction, flexion.
Yeah. So that's for our study, the Physio First trial. So the Physio First trial is an RCT where we looked at the effects of different exercises in people with FAI syndrome. So all of those exercises were listed in the protocol that we published in BMJ Open, looking at for the Physio First trial. So people should, and that's an open access paper, so people should be able to easily download that if they just look up my name and then Physio First and BMJ Open, they should find that easily. And the results of that trial, we're in the process of getting published at the moment. So that manuscript's under review. But you can absolutely go to the protocol, and all of the exercises are there with photos and exactly how many to do and how often. So it should be, it's a nice way. I think it's, like you say, it's a good starting point for people who are treating patients with hip impingement to get an understanding of the types of exercise they should do.
Yeah, that was very helpful to visualize it. And now just going back to the groin pain, hip related, right? That you said a hip joint. Is that the treatment similar to the ones that you mentioned before, or do you treat them differently?
Yeah. So the hip related groin pain refers to those three, either FAI syndrome or hip dysplasia, or the other criteria. So as long as you can get an understanding of that, then you would treat based on that, then you would treat them appropriately.
Okay, so it's the same. It's the same thing.
Yeah. So the hip related groin pain, you can then take that and then you split it into those other three criteria.
Okay. It's just because the location of the pain might be on the groin.
Yeah, so that's right. So that's right. So the groin referring to that whole kind of anterior sort of lower part of the pelvis. So like we were saying before, the location of the pain. So even though it's all the groin itself is quite a big area, and it's a fairly non-specific area. So that's where we can drill in. If it's very central, it might be pubic. If it's more to the side, it might be hip related. If it's down lower, it's probably adductor related. If it's up higher, it might be more abdominal related. So even though it's the groin, it's a reasonably big area that it covers. So, but yeah, the hip joint pain can be, it's usually it's not right in the center of the groin. It's usually slightly to one side, to the side that's most effective, but it can definitely refer into the groin. And sometimes hip pain can even refer down onto the inside of the thigh or the outside of the thigh. And for some people, it even refers down into their shin, so down below the knee, into their shin and into their ankles. So particularly with arthritis, patients with hip arthritis can often present, they might not even have pain in their hip, they might have pain down in their leg further, but then have those loss of hip movement. So hip arthritis commonly refers down into the leg and even into the shin and the ankle.
Wow. What's the explanation for that pain referring so low?
It's just a referral. It's a referral pattern of the arthritic joint can refer distally. So, yeah.
Very, very interesting. And do you treat the other type of groin pains, like the iliopsoas that you mentioned?
Yeah, absolutely. So depending on what the athlete, so usually that's in athletes, they'll have those other sorts of pain. So absolutely. And so that's why having a good understanding of what the source of pain is really important, because it will change your treatment slightly. So if it's adductor-related groin pain, they probably need to have a focus on adductor strengthening. If it's iliopsoas-related groin pain, then they'll need more of a focus on iliopsoas strengthening exercises. But by the same token, it's important that you assess each patient individually and get an understanding of their impairments, because their impairments might be slightly different from person to person, which is where doing things like assessing muscle strength with a handheld dynamometer, assessing their function, having a good understanding of what sport they play and what they want to get back to doing is really, really important as well.
Mm-hmm. And in general, like, what are the results that you see with your patients treating them with exercise conservatively, and when or what percentage do you see the need to refer to a doctor, potentially having surgery, How do you see that?
That's a great question. And really, it's a really important question, I think, as well. And generally speaking, what I see is that most patients will do well with a conservative exercise-based approach to their injury, but not everyone will. And there are some patients that you do need to refer on to see a surgeon. And that's the case whether it's hip osteoarthritis or hip impingement or dysplasia or whatever. So generally what I would do is I would like to see improvements. So with all of our exercise programs, we know that the patients need to do them for probably at least 3 months for them to be really, really effective. Doing them for less than 3 months is not likely to work so well. So, but in saying that, I would like to see improvements before 3 months. So I wouldn't wait for 3 months before I would start to be thinking to myself, maybe this patient isn't going to go so well. So I'd like to see some progression towards improvement, probably in the first month to 6 weeks, and see some positive changes. And if the patient hasn't shown any change in that month to 6 weeks, then I'll probably start to talk to them about other treatment options and get a feel for whether they're open to surgery, because not everybody, depends on what country you're in and whether you're not, what the cost of surgery is, but surgery is not appropriate for everybody. So I think it's really on a case-by-case basis. But I would say to the patients, it's going to take at least 3 months for our exercise treatments to work, but I'd like to be seeing some improvements in a month to 6 weeks to know that we're going in the right direction before I would think about referring them on to see a surgeon.
What drives me crazy, at least in the US, like I had patients that they start feeling pain like a month ago, and they're coming for a pre-op of hip replacement. It's like,
I know.
So quick. I was
too
like,
soon.
how?
Yeah.
Yes. They don't even want to try, or the doctor doesn't even tell them to try. And they just like out of the blue, they start feeling pain and they're going to hip replacement like as soon as like a month later.
Yeah, I know. It's too soon. And the thing is with hip replacement is a really good operation for people who need it. So it's probably one of the most successful orthopedic procedures. But even in that, there are 10% of patients who have a hip replacement who don't do well. So, you don't want to be, like you said, you don't want to be that in that 10% of patients who, because once you have a hip replacement, you can't turn that back, right? Once the joint's been cut out and thrown away in the rubbish, you can't get that joint back. So you want to be absolutely certain that you've tried everything first before you progress to surgery. But for some people, they do need to have surgery, absolutely, but that shouldn't be before they've tried at least 3 months of really good quality exercise therapy to know whether or not that's going to be suitable for them.
Yes, it's crazy. And that's the minority of the patients that you see, you believe, that need to go to surgery.
Yes, minority. It is the minority. Some do, but most don't.
And then with the impingement syndrome, do you see them having the need for surgery as well? Or do you see mostly the osteoarthritis replacement? So
with osteoarthritis, the only surgery that's really an option is a hip joint replacement, and there's different sorts of replacements that you can think about. But with a hip impingement, so an arthroscopy does not work in people with osteoarthritis in the same as in the knee. You wouldn't do an arthroscopy. But for people with hip impingement, so FAI syndrome, hip arthroscopy is the surgery that if they were going to have surgery that they would potentially have. So where the surgeon would go in and reshape the bone and repair any damage to the structures. And hip arthroscopy in people who have FAI syndrome where exercise treatment hasn't worked, hip arthroscopy can give them some benefit. So there have been a number of randomized controlled trials that have been done that have compared hip arthroscopy surgery to exercise therapy in people who have been referred to the surgeon. So they've been told that they need surgery. And in those people where they haven't responded to exercise therapy, hip arthroscopy gives them probably about a 20% improvement in their symptoms, and a bigger improvement than they would get from exercise therapy. So if exercise hasn't worked for a patient, then hip arthroscopy can be a worthwhile treatment option. And it's just really important that the patients understand how much improvement they're likely to get from hip arthroscopy, and that while they'll definitely improve, they're not going to go back to being the same as someone who's never had a hip injury. So they still probably will get some pain from time to time. So even though they'll be much improved on what they were, they still won't be completely 100% cured of their hip problem. So I think it's really important that they understand that before they make the decision to go to surgery. But certainly if someone has hip impingement or FAI syndrome and they haven't responded to exercise therapy, it's certainly a treatment option that they could explore.
Mm-hmm. And for the ones that respond to exercise, I assume that's a very long-term approach, right? They're going to have to be always doing some type of strengthening, right, to maintain their hip well.
Yeah, it's true. But then I guess if you think about the WHO recommendations for everybody, for all human beings on the planet, should be doing 2 strengthening sessions a week as part of their exercise program. So with someone with hip impingement, what I try and do is build their strengthening into their fitness programs. So don't make it like rehab home exercises, because we know everybody gets a little bit tired of them after a while, but making sure they build some hip strength into their general strengthening program or their fitness training program that everybody should be doing.
Mm-hmm. Awesome. Before we go to our final questions, anything else you want to add?
No, I think it's been lots of information. Yeah.
Okay. And if people want to learn more about the topic, do you have any recommendations, resource of information, papers?
Look, there's lots of, as you said at the start, there's lots of papers in this space, and we've done a lot of work in this space in our group, and many others have also done really, really good work. So if someone's interested in reading research articles, then I would just recommend going to somewhere like Google Scholar and just putting in the search of the topic that they're interested in, or putting in the search of, you could either search using my name or others' name in this space to get research articles. And there've also been a number of books that have been published that have chapters specifically in this space. And so an example is the Clinical Sports Medicine book. That's a good example where there's resources as well in those places too. And then our research centre, the La Trobe Sport and Exercise Medicine Research Centre, has a web page that has some resources and things attached as well. And the GLAD Australia website has good resources for hip osteoarthritis.
I was going to ask you where the listeners can find more about your work. You already answered that one. So they can go through your list of publications, and there are a lot of papers that you publish there. Joe, any way that if anyone wants to contact you or find, is that a way that they can reach out to you?
Yeah, look, probably the easiest way is just via email. I used to do Twitter, but I don't do Twitter so much now that it's become X. So probably the best place is on email. So you can email me on my email address, which is the letter J.Kemp, so KEMP @latrobe.edu.au, and happy to try and answer any questions that I can over a brief email exchange.
Awesome. Thank you so much, Joe, for taking the time and giving us this great overview. We learned so much information, so I appreciate your time and your availability to come here, share all of this with us.
It's been my pleasure. It's been lovely to chat to you as well, Mariana. Thank you.
That's all for today's episode of PT Pro Talk. We hope you enjoyed this discussion. Be sure to follow us wherever you listen to podcasts, so you'll be notified when we release future episodes. You can also join our email list at ptprotalk.com to receive updates and access new episodes. If you have ever gotten value from the show, please take a moment to leave us a 5-star review. It always makes my day, and it really, really helps us out. If you have any guests or topics you'd like to see on the show, let us know by answering a quick survey. You can find the link in the show notes, along with more information about our guests, resources, website, and social media. Thanks again for listening, and until next time.